Good morning, everyone. Very pleased to be here. I would like to thank Dr. Ullas for giving me this opportunity. So my talk will be quite antithesis of what was going on till now. Till now you were listening about many rules, many things that you should remember to make a diagnosis. What I am going to do is put some doubt in your mind and tell you things which you should remember to not to make a diagnosis. So a reasonable doubt is a good thing to have. You should not doubt your decisions too much, otherwise you can't make it. But you must have a reasonable doubt so that you can make it a better decision or an informed decision. Second thing, you must remember that never be dogmatic about your diagnosis. If somebody is offering you an alternative diagnosis, there's no harm considering that opinion and then ruling it out. So all these things, they make your predictive value of your diagnosis go higher rather than just relying on the books and the guidelines and the criterias. Because those guidelines, those criterias are made, all these criterias, they are not written laws by God. They have been taken out from various trials. And these trials have a select subset of patient in which the disease prevalence is higher. So the specificity and sensitivity and positive predictive value, everything is related to disease prevalence. So you cannot apply that in your emergency room where things are different. So you should always have a reasonable doubt. Okay, so how common is this issue? So if you see how common is chest pain in the emergency department, it's quite common. But if you see how many patients are actually having MI of those chest pain, it's not more than 15-20%. It depends upon, again, what kind of institute you are practicing in. If you are outside, institute which is not known for cardiology, you're going to have a prevalence of actual MI in your emergency room much lesser than even this 15%. Whereas in an institute like Jayadeva, where people go if they have chest pain, so there the prevalence of MI will be higher. So your positive predictive value will be higher of the same criteria in Jayadeva as compared to in the peripheral center. So it's all the more advisable to have this reasonable doubt in your mind if you're working in such center. So what are they? What are the mimics? LVH is there, left bundle is there. Acute MI is, mind you, it's not even the single most important cause of ST elevation. If you talk about in normal population, early repolarization has been reported around 5 to 10%. So it's the most common cause of ST elevation. So acute MI is not even the most important cause for ST elevation MI. So whenever you see ST elevation, don't jump on MI. You have to see the patient. Remember, ECG is like a window to the patient, the real thing. It's not the diagnosis or the disease itself. So anybody can recognize, machine can recognize. If you give positive reinforcement to a monkey, maybe, it will be able to recognize ST elevation. So it's not a diagnosis, ST elevation. So what are the harms, if you report everything as MI? So it compromises your system. If you're in an institute with a cath lab and every time you tell your consultant, cardiology consultant, we have a MI, you have a MI. The cath lab technician is alerted up, nurses get alerted up, and it compromises because it's like wolf has come, and there's no wolf. People stop believing you. It weakens your true positive. So if you make wrong diagnosis again and again, then you will have doubt on yourself that you're not doing correct. So it weakens your true positive. It misses the alternative diagnosis. You can miss a aortic dissection. You can miss a lot of things if you make a wrong diagnosis. You can give wrong treatment, and it degrades your professional respect, your colleagues, your everyone. So that is also important. So what are the tools to diagnose MI? Not just ECG. You have to see the clinical correlation. You have to see history, risk factors. 70-year-old coming with a chest pain and 25-year-old coming with a chest pain, you will think 10 times before making MI diagnosis. Older ECGs, documents, serial ECGs, time out, give some time. You tell the patient, if you are in very much doubt and you think that the MI will not be there, you have a reasonable doubt in your mind, repeat it. Repeat the ECG after some time. You see if there is any progression or not. Expert consultation, it never harms anyone. If you're in doubt, today you have WhatsApp, you have everything, click it and send it. So important thing is that there's no clinical sign and symptoms which are completely reliable, no ECG findings which are completely reliable. History may fool you, what patient might be saying, I'm having chest pain, a central kind of a chest pain, and another person comes and he'll tell something else. So you have to see the complete picture. So how to differentiate? What are the tools which are in ECG which will help you to differentiate from MI versus non-MI? So you have morphology, you have magnitude, you have distribution of ST elevation, you have prominent electrical forces, you have ECG mimics with QRS width and other features. So let's go all of them to one by one. So there are variable shapes of ST segment elevation in MI. So this is the smiley face shape, this is a convex shape with the QS, and this is a horizontal ST segment elevation. Morphology is important. You know that if it is concave upwards, and one thing more, all these slides will be provided to you, so it will be much more wiser to listen, and everything will be provided as a resource material. So concave shape ST elevation is not MI, and convex is MI, we all know that. So what else is convex, what else is concave, and which we are, we should be very careful about, which is one of the most common causes of ST elevation that you will see. So this will be the early repolarization syndromes. So you have a concave ST segment elevation, you have large amplitude T wave, which is important, and you have notching or slurring of J point. So if you see this, it's not MI. It's very, very unlikely to be MI. So what are the ECG characteristics of early repolarization syndrome? There's a ST elevation, which is not much as compared to the QRS. So the QRS to ST and T is to ST is actually less than 25% as compared to MI, where it will be more than 25%. So ST elevation is less than 2 mm, concavity, which all of you know, smiley face, notching or slurring in the terminal QRS complex, symmetrical concordant T wave, large amplitude, widespread or diffuse, no territorial distribution, this is again important, and relative temporal stability, this is very important. If the same patient has, many times same patient will have chest pain day before yesterday also, he would have gone to another hospital with another ECG, and you see both of those ECG are having ST elevation. So he can't be having MI for 2 days and still no QS. So you know that it is early repolarization syndrome. So this is the smiley face, all of you know that. This is the J point, notching in the terminal QRS. This also you know. So what is the prevalence? The prevalence of ER in a general population can range from 1 to 13%, again depending upon what population are you sampling. In young adults it will be more. As you grow old, the prevalence goes down, so it will be less. In athletes it will be more, blacks it will be more, males will be more, so again it depends on your sample size. But the important thing is that it is quite high. 5 to 10% is not a small number. And why does it happen for the brainy ones? So normal and early repolarization. Normally your endo, epi, all the portions, they get repolarized at nearly simultaneous rate or nearly simultaneous time interval. On the other hand, in early depolarization, some portion of heart get repolarized early as compared to the other portion. So in phase 2 and phase 3, there is a voltage gradient. And this voltage gradient can give rise to injury patterns, similarly like you have in ST elevation MI. So if you see, there are two things which you notice about early repolarization. One is the J wave, the notching, and the other thing is tall T waves. Both things can be there. So one pattern, one variety has a large voltage gradient to begin with, and then suddenly the voltage gradient decreases. So this variety will give you notch. The other variety, there is a voltage gradient across the repolarization window. So the gradient keeps on increasing, the voltage gradient in epi versus endo. So you get this very tall T wave. So both these things can be present in the same patient. So that is why you get these things. Now, you must remember that early repolarization, Brugada, short QT, people are coming to realize they are spectrum of the same thing. There are no genetic mutation found for ERS as compared to Brugada, so that is definitely there. But the same kind of pathophysiology is there in both of them. So early repolarization syndrome, this diagnosis, I wanted to ask your opinion, but I'm telling you. So you see that there's a notching, you see ST segment elevation. Now, mind you, T wave can be long, but ST elevation will be less. This will be less than 25% of the T wave. As compared to ST elevation in MI, even if you have a tall T wave, ST elevation will be more than 25% of the T wave. So that gives you an indication that this is ERS, this very tall, suddenly the voltage gradient stops. And similarly, you will see the same thing in the inferior leads. Now, this patient can't be having MI here and here both. Again, you have to see the whole clinical picture. But this is a classical picture of early repolarization syndrome. Early repolarization syndrome can be of various types, type 1, type 2, type 3. So there's one variety in which you get only in the precordial leads. There's another variety in which you get only in the inferior leads. And there's another variety in which you get in all leads. So any variety could be there in your patient. So you have to keep an open mind. So this is the same patient, again, ECG few days back. Now you have to remember when you're using the timeout principle that early repolarization syndrome, the ECG can change in the same patient. So temporally, it is much more stable than MI because MI ECG will change very soon. But early repolarization syndrome, if you compare ECG few days back, few months back, the ECG can be different. Again, it's ion channels which are susceptible to hormone milieu and a lot of other things. So the ECG can change of the same patient. So coming to another thing now, distribution. So that was the shape of the QRS, shape of the ST segment. Now coming to the distribution, how that will guide you in ruling out the mimics. So the previous speaker gave an excellent idea about the distribution of MI and how to diagnose MI. Now I'm going to tell you what is wrong in the distribution or how can you pick up other things. So if you see diffuse ST elevation, apart from early repolarization syndrome, another thing which can go wrong is pericarditis. So in pericarditis, you will see diffuse ST elevation, and again it will be concave. So it's like early repolarization syndrome, but you don't see, there is an injury in the pericardium, and that's why you get these injury vectors and ST elevation, but you don't see the J wave. So what is the difference between ST elevation, ST and pericarditis and in MI? In pericarditis, it's concave, and in this, it's convex. Pericarditis is diffuse, it is territorial. PR depression, now this is very specific, not very sensitive, but very specific for pericarditis. And T wave inversion in pericarditis occurs only after ST normalizes as compared to MI, where T wave inversions start when the ST is still up. So these are the patients with with pericarditis. So you can see that there's a diffuse ST segment elevation, and if you see carefully, you can see over here that there are very small, minimal PR depressions. Now these, again, this is the same ST elevation in case of pericarditis. It's easy to miss out these patients. Now again, you have to look for the whole clinical picture. I'm not saying each and every ST elevation like this you will diagnose pericarditis. No, not at all. But if you think that there's something different about this patient, he's not complaining of the classical MI symptoms or chest pain, it's just the ECG is this alarming, but he's complaining of different symptoms. He's complaining of fever instead of chest pain. So if you see this kind of ECG, then don't rush for MI. You have reasonable doubt, look for pericardial rub, do an echo, do an blood investigation, try to see this kind of patient will be temporarily unstable. So within few hours, he will worsen. So look for all those things and then make your diagnosis. So how do you differentiate, again, early repolarization and pericarditis? Again, pericarditis and early repolarization, important thing is ST to T. Because in early repolarization, like I told you, the T waves are tall because there is a voltage gradient. Unlike in pericarditis, where there is no voltage gradient, but there is an injury current because of the inflamed pericardium. So you don't get tall T waves, but you get ST segment elevation. So the ST to T ratio, the ST will be taller or more than 25% of the T wave in pericarditis. But in case of early repolarization, ST will be smaller than the total T wave. So now coming to Brugada syndrome pattern. Again, this is territorial. So like pericarditis can be pericarditis, there is no regionality. As compared to Brugada, there is a very exact regionality. So territorially, it is limited to lead V1 and lead V2. So if you think abnormality, if you see abnormality in only lead V1 and V2, think about Brugada if the patient is complaining syncope. So this is how a Brugada type 1 looks like. So this is very alarming. I'm not saying just because it's not MI, it's not alarming. It is very alarming if you see this kind of ECG and patient comes with fainting and all, giddiness, those kind of symptoms. But it's not MI. So that is important to realize. And similarly, this is type 2 Brugada, this is type 3 Brugada. And the difference is that there is a spontaneous coving. There is a concave upward with more than 1 mm elevation. This is less than 1 mm elevation with concave upwards. These criteria are very well mentioned in all your books. This is just an prelude to what you will go and study. So you have to make this kind of diagnosis. Now, how common is this mimic, and where mostly you see this mimic? There's another thing. Brugada pattern and Brugada syndrome are two different things. So a person can come with chest pain, not typical syncope, not fatigue, not fainting, maybe atypical chest pain, and he will come with this kind of ECG, and you can call it Brugada pattern, but unless he is having classical fainting and all those syncope and everything, family history, you won't call it Brugada syndrome. So Brugada pattern is this pattern which I showed you. So this is Brugada pattern. So it happens more commonly if your technician of your staff in your emergency department, instead of putting leads in V4, they are putting your V1, V2 leads in intercostal space 2 and 3. How common can they be? They can be very common. Brugada pattern are easily observed in high precordial leads, in college athletes, in students. The population prevalence in second and third intercostal space can go as high up to 4 to 5%. So the pattern can be very common if you are measuring it in higher chest leads. So 11% is alarming. So you see this in standard chest leads, you're not seeing much. If you go in higher chest leads, you start seeing Brugada pattern. So similarly here, standards not much, high lead Brugada pattern. Now again, keep reasonable doubts in your mind. So why is this so common? There are various causes of Brugada. There is a mechanical cause, pectus excavatum, mediastinal tumors, abnormality, metabolic causes, myocardial, pericardial causes. So Brugada pattern is very common. So what I want you to take from this is, if you see a Brugada pattern, first of all, if you recognize those two patterns in lead V1 and V2, it's not MI, it's a very classical Brugada. And you see there's no ST elevation. There is a ST elevation like this. Yeah. So it's a very coved ST elevation, and then ST is kind of merging with T wave. This is very classical. And you see only this, no reciprocal changes, nothing. And patient is not complaining of the classical MI symptoms. There will be no temporal progression. Brugada patients are also known to have, this temporal variability in their ECG. It won't be as fast as MI. So for example, in MI, there is a evolution in 1 hour. In Brugada, there won't be any evolution in 1 hour. But again, if you see old ECGs, you will see difference. So the ECGs of 2 days back might be different from today. So again, you have to keep that in mind. So what you have to make a diagnosis of is a Brugada phenocopy, and then you have to decide whether it is Brugada or not. But one thing is clear, it is not MI. So if a patient comes with a history like this is Brugada syndrome. Again, what is this? It is just, ECG just to show you. Is this MI? No, I'm showing it with Brugada doesn't mean it's Brugada. It is ischemic? Okay, so it looks like ischemic, but if we look closely, there is a ST elevation, T wave inversion, maybe only slightly in this. There is no loss of R wave. R waves are pretty much okay. There is nothing, no reciprocal changes. And this is not the classical ST elevation you see in MI. And if you see up to 2 mm, like the previous speaker was saying, in the precordial leads, it's okay. I mean, you can get it in even normal population up to 2 mm. This is not more than that. And similarly in V1 also, and you're not getting into contagious lead. There's only one lead which is showing 2 mm. Other leads are not even showing that. And if you look closely or carefully over here, you'll see a blip. Similarly, you will see a blip here. So this is ARVC. So again, don't be fooled by just because they are in 2 leads, it is Brugada. It can be ARVC also. So remember these patterns. What is important is to realize V1, V2 is something specific for Brugada and ARVC. So whenever you are seeing ST elevation in only VR, V2, V3 is very, very, very uncommon for Brugada. So if you are seeing in V1, V2, always keep these 2 differentials in your mind, Brugada and ARVC. There is nothing like MI here. Okay, so now coming to mimics of wide QRS. So ST elevation MI mimics with a wide QRS. Now the previous speaker very nicely elaborated on Garbosa criteria, and we know that it's supposed to help us, and it does help us. That's what it is used for. So I'm not going to repeat it again. So important points. You know about predictive characteristics of Brugada. So of Garbosa. So in his original paper, the sensitivity and specificity of these criteria were like this. So if you go by the important criteria, which is the concordance criteria, these are the important criteria. So concordance criteria has sensitivity and specificity of around 73 and 92. The discordance criteria, that is discordant ST elevation of more than 5 mm, that criteria has a poor sensitivity. It's very common, you know. So only 31 and 92%. So this is the kind of sensitivity specificity it has. So you remember that. We will come back to it later. So if you see the total predictive accuracy of the original Garbosa paper I'm talking about, the sensitivity of all 3 combined was 78 and specificity is 90%. Now we'll just go what happens in your emergency room with this kind of sensitivity specificity. And mind you, these sensitivity specificity are the original paper, which is supposed to be the most selected cohort. By the way, these criteria were validated in other groups, so it helps, okay? So I'm again just opening your mind and creating reasonable doubt. So this is LBBB. So what you see here, anyone? Okay, so it's just LBBB, there is nothing there. Okay, and what is this? You want to see the previous one again, difference between this and that, the earlier one? So this is the earlier one, it is the same patient. So this is the earlier ECG, and this is the current ECG. Anything different here? Yeah, so there is concordance pattern. So you see V2, there is a ST depression, and there is ST depression in V5, V6. Most importantly, there is ST depression in V2, which is concordant. You see how it was before. There was ST elevation. So now there is ST depression. So this is the most specific criteria of Garbosa. So this you have to look for. So if this ECG comes with a classical history of chest pain, definitely make a diagnosis of MI in this patient. So this is, what about this? Again, same thing. This is a LBBB patient coming with this kind of, V2 doesn't look like this in LBBB. It should be tall, you know. There should be discordant. So there should be a secondary T wave changes. When we say tall, it should be secondary T wave changes. And when MI happens, these are primary T wave changes. So LBBB with this kind of pattern has both secondary and primary. And the primary is more than secondary. That's why you see depression instead of ST elevation. So you also see ST elevation in inferior leads. So this is LBBB with MI. This is again same. So Garbosa principle is very good in diagnosing MI in presence of all these mimics, because it can be used for LBBB, RBBB, LVH, paced ventricular rhythm, non-paced ventricular rhythm, including PVCs, WBW and other pre-excitation. It has been validated in all of them. So it is one of the most important criteria to remember. Now, discordant ST segment elevation of more than 5 mm is not good, and which the previous speaker has already told you, because you can have a lot of false positives. Okay, so I'm just finishing it. So important thing to remember is with all these sensitivity specificity, if your population prevalence, like if your prevalence is 50%, the predictive value is 89. But if your prevalence is only 5%, predictive value is 29%. What this means is, if you make a diagnosis of MI with Garbosa criteria positive, in 100 patients, only 30 patients will have MI. Positive predictive value means this. So 70% of the time you'll be wrong. So again, keep an open mind, not go only by criterias. So this is again a very important and funny paper. So they applied the Garbosa criteria algorithm in LBBB patient, and in other group, they didn't do anything. They thrombolized all LBBB. And there was no difference. Whether you make a diagnosis with LBBB criteria and then thrombolize versus don't do anything and then thrombolize, there was no difference. And reason is why? Because positive predictive value is only 50%. So it is just like tossing a coin. So there's not much difference. So I'll skip this. So all these resource material will be available. So you can use it for RBBB. Similarly, you can use it for WPW. The idea remains the same: discordance and concordance. So in WPW also, it will be discordant. Normally, you see a discordant ST changes as compared to your QRS. But if you start seeing concordant, then that means it is MI. So just apply your Garbosa in this also. Sorry, I have to finish this. So another important thing, hyperkalemia. Now this is important, so I'm not going to skip that. So manifest ECG that can resemble acute coronary syndrome. Why this is important is because you are having a dialysis unit. A lot of patients will be coming with this kind of problem. So what you see is something like this. Now whether it is hyperacute phase or not, so they are different. If it is symmetric, if it is narrow base and slim T wave, if it is sharp pointy tip, if it is concave upwards, then it is hyperkalemia. As compared to acute MI, it is asymmetric, wide base thick, dull peak, and it is convex ST segment. So similarly, you can have something like this. This is a paced patient with ST elevation. T wave, it looks like MI, right? But this is hyperkalemia. Same patient after correction, T wave becomes smaller. Same patient after correction, he's in LBBB. So he doesn't require anything. So left ventricular aneurysm, this can also give you the important point to remember in left ventricular aneurysm is that you have a very deep S wave. So your S wave is too big for ST elevation. So if you are having this kind of pattern, it's an aneurysm pattern. In brain injury, intracranial hemorrhage also, you can get this kind of ST elevation pattern. And remember, the patient will be very sick, moribund, GCS very low, complaining of headache. So don't be alarmed by just seeing the ECG. Subarachnoid hemorrhage also has ST segment elevation. So post-DC shock, again, this will be situational. After shocking, you will get this, otherwise you won't. So finally, I would like to conclude. Keep an open mind, see the whole picture, see the old record, see the history, see the clinical picture, know the diagnostic accuracy of algorithms you use, and know the prevalence of suspected disease in the population in which you are using. Young patient with ECG ST elevation, 25-year-old, will have a different diagnosis as compared to 70-year-old patient with diabetes. Time out, take some time, think again, and last of all, seek help. Preferably human help. Don't go for Google, and because these are not good for making acute diagnosis when the treatment is at stake. Don't go by that, because that will give you biased information. You'll get information what you're looking for. It won't give you the other view. So don't go for that. You seek preferably a human help in this. Thank you.